Hello, everybody. Good evening to all of you in Kenya. My name is Ting. I am working as an anesthesiologist in University of Washington, and I've been putting together this virtual didactic series for our collaboration with the UW Global Anesthesia Initiative with Naivasha Hospital and University of Nairobi. So thank you all for joining. Today, we have our second lecture of our virtual series focusing on pediatric topics. Before I introduce you to the speakers, I want everyone to know we have another lecture next month on the topic of pediatric fluid and blood transfusion, and we are adding another topic about pediatric traumatic brain injury later. So stay tuned for information about that to come. So without further ado, today we are talking about pediatric and neonatal resuscitation. Our presenters, I'm very excited to introduce are Dr. Diriba Fayisa. He is currently undergoing subspecialty training in pediatric anesthesia in the fellowship at the University of Nairobi. Was previously a consultant anesthetist, and also Dr. Andrew Pintea, who is a consultant pediatric anesthesiologist at Seattle Children's Hospital. So thank you both for doing this lecture, and I will hand it to you.
Nice. Thank you very much for introducing us. Thank you, Isha and Dr. Andrew. I think we can proceed, right? So I think we have searched some people. Today, we'll see. I don't think we'll dive into the details of resuscitation, but we'll try to have just the basic ones, what we need to do in general, and for all of us to understand just the basic one. So it's covering both the pediatrics and the neonatal, yes, beyond the neonatal age group and neonatal age. So we can say this almost two topics. So we'll proceed with that one. So when it comes to disclosure, I don't have any issues on financial and disclosure. So, and these are my objectives, or general the objective of this topic. We need to recognize neonates in need of resuscitation really, and how to assess hospitals and how to use really or understand the steps of golden minutes, and finally the practical part, how to perform neonatal resuscitation, and those age group beyond neonatal age group, usually call them pediatrics. So there is one scenario we'll start with as we go through all these slides, especially in the neonatal resuscitation slides. We'll think of this scenario. Just it's obvious that the anesthetists of different level, they will come into just CS room to give a spinal or general anesthesia, whatever it is, for mother giving birth. So, for example, if you found a baby who's floppy, really not breathing, and pale, as you assess initially, and the obstetrician is closing up the skin and he wants you to take care of the baby. And in this scenario, how do you approach and what will you take, the measures you are going to apply in situations of resuscitation? And you'll think of this scenario as we go all this through the slides. So I don't ask anyone now, and I don't want anyone to reply or respond for me now. So as introduction, is almost 10% of newborns need some sort of respiratory assistance at birth, even though very few. less than 1% needs extensive or detailed resuscitation, which needs algorithm we need to follow. So it's not still something we don't ignore. This is a big number, so we need to give attention to neonatal resuscitation. Epidemiologically, when you see worldwide in 2016, 46% said the death is under 5, which usually occur in newborn rate. And when you see the neonatal mortality rate is almost around 19 per 1,000 live births. And of this, when you compare the European and developed countries and the middle and lower income countries, is more of which is occurring in the Eastern Asians and African countries. So as we are talking, almost all of us in the low income country, so we need to give attention to this topic really. So WHO has updated some on what need to focus on when we give neonatal resuscitation, yes, which was revised on 2017, and give attention to the things we say it is minor, but still plays a great role. So like keeping babies warm and supporting breastfeeding early, which will also just go with keeping the baby skin to skin contact with the mother. So recognizing and treating infection early. These are the areas updated on WHO recently. And the other is cutting the cord. This issue, it depends on the status of your neonate when you assess the baby initially, which we will see after a few minutes. So it's said to be 1 to 3 minutes after delivery. You need to keep the cord intact just to prevent newborn anemia usually. So this is it. And as you know, there is a difference on resuscitation between neonatal age group and adults. So these are pertinent to physiological changes and really the occurrence of hypoxia because of arrest or whatever in neonates and pediatric age group. And there is a scenario or a situation when we just don't need to resuscitate babies, especially if they are really preterm and if you are not in advanced setups or we don't have facilities to support the babies, especially preterm, less than 28 or less than 1 kilogram. If there is nowhere to repair the babies, and you can easily just recognize those who are not compatible with the environment. Just preterm babies, you can just bypass resuscitation. And lastly, if there is no response to your resuscitative attempts, you can just stop. This is a WHO suggestion. There is a minute cut time, just 10 minutes without any sign of life, or 20 minutes if you are having a heart rate of less than 60 per minute. So you can just quit resuscitation at this time. And the other is congenital abnormalities, which are not compatible with life, like anencephaly and the others, gross anomalies. You can't really cope up with the life. You can just leave the resuscitation. No need to blame yourself or the staff taking care of the baby. So there are basic principles we need to follow during a resuscitation of the neonates. And the first thing for all is preparation. Yes, which we'll see in terms of what we are going to prepare ourselves and what we need to prepare. Just the equipment, the staffs we need to have. And this depends on the risks you identify antenatally and intrapartum and the situation you are in. It will determine the staffing who are going to attend the delivery. So there are charts. Okay. To say something on this, especially it is good to have a personnel who are really have an experience on neonatal resuscitation. Otherwise, it's obvious that it's not as that of adults or big pediatric age group. So we need to give attention to the personnel who are taking care of these babies and the staff who are with us during resuscitation. And when you see the occurrence of arrest neonatal age group during perioperative period, there are common neonatal emergencies. You need to suspect the possibility of arrest so that you'll prepare yourself accordingly. These are some of the lists you really know. I know most of you are aware of it. So like necrotizing colitis, meningomyelocele, atherosclerosis, and you can list them. So what makes this different from the one in delivery room is, yes, about you know the case, so you have the time to prepare yourself really, just irrespective of any situation around you, you know the baby, so you can prepare yourself accordingly. And the other is you can prevent still the occurrence of any arrest or the need for resuscitation. And if it happens, you have the time to identify the problem early, so you can do that. And lastly, you can intervene accordingly, depending on your finding, whatever the baby's in. And regarding preparations, it includes all the equipment. Here is not the mere presence of equipment. You need to make sure the equipment is really functional and is ready for use. And while preparing your equipment, you can have your checklist so that you will not forget or you will not miss any, which are really needed for your resuscitation. And when you perform this, you have to make the environment is really illuminated with full of light, but there is no windy and the baby is not at risk for hypothermia. And you need to keep the baby warm all the time. So if possible, at any cost, it's good to prevent hypothermia, which is the usual risk for any other scenarios or which will affect our resuscitation. The equipment monitor should be just, you can have the advanced ones if available, like ventilation even, which is the last resort actually, but if available, you can have it. So these are for you to remember. You can post it where you perform your neonatal resuscitation in rooms or where you think it is really mandatory to post. Just you can go through the important things and you can have them with you. And when you come to resuscitation, here still I focus on just minimizing heat loss, even though it's really difficult to prevent at all, you can minimize it. So at any step, you'll prevent heat loss. So this is, it's a radiant warmer. I hope those who are familiar with this, you will have it in your theater or in delivery room. So you can put the baby under this radiant warmer. So when you assess, just it needs to be fast because there is a golden minute we are talking about. So when you assess, you have to use your all senses, like you have to quickly observe the tone of the baby, the color, and the effort of breathing, whether the baby is crying or just trying to cry or not breathing or trying to breathe. And when the baby is at your hand, you can check for the pulse or the heart rate. So even during this time, keep the baby warm still during initial steps. And this pulse assessment will help you to determine whether you are going to keep the cord intact or you have to cut it as fast as possible to go for resuscitation. So, and you will not stop once you assess the initial assessment, you will continue reassessment, don't stop, because the baby was really in a moderate range can just progress to really in need of detailed resuscitation or extensive resuscitation. So don't put the baby aside and keep close to the baby. And we have 3 categories on depending on initial assessment. There is a red, just green, yellow, and red category, which will go with satisfactory effort, and incomplete and the poor. Will go through these slides and we'll see each of them. And the satisfactory transition lies in the green range, which is a good tone, vigorous breathing, or the baby's crying, and the heart rate is just greater than 100 per minute. So this baby needs just to delay cord clamping, which we're talking about 1 to 3 minutes, and you can wrap with warm towel and keep the baby with the mother with skin to skin care. The baby is stable and still just maintain the temperature. And the second one is incomplete transition, is which will lie in the yellow range with reduced tone. The baby might be apneic or inadequately breathing with still some effort. So we need to give attention for this really, and the heart rate will be less than 100 per minute. So for this baby, what we need to do is, there is a possibility of hypoxia. As you all know, hypoxia is a common cause of bradycardia because of the autonomic development. You all know the parasympathetic dominates than the sympathetic, so it will respond as bradycardia for any stimulation like pain or hypoxia. So give attention for this baby. You can delay cord clamping only if you are able to appropriately support the infant after all. Otherwise, there is no need to delay the cord clamping, and still drying and stimulating the baby is the next step. And as you all know, we don't really need advanced airway manipulation in neonates. Just with little airway manipulation, you can overcome the problems with hypoxia. So maintain the airway. You can use lung inflation and the ventilation, and continuously assess the baby after your initial lung inflation and the ventilation. After you manipulate the airway, just chill lifting and putting the baby in neutral position. This can do a lot of things. Just not don't rush to intubation as easy as this one. So you may need help. So anytime, don't hesitate to call for help. If you feel you need help, just call for help. And the third one is poor transition, or which we call pale. Here, the baby is floppy and pale. There is no breathing, which is inadequate, or the baby is completely apneic, and the heart rate is less than 60 or maybe absent. So here is the time for you to rush for resuscitation and have your team with you. You can directly call for help at any cost. So it's obvious that the baby is having some sort of significant hypoxia. So the thing you need to do is clamp the cord immediately, just for the purpose of resuscitation. And as usual, you will keep the baby warm with a dry towel, and you need to maintain the airway as we have been saying in the previous slide. And you need to continuously monitor and assess for the heart rate, breathing, and just the effect of ventilation. And as I tried to say, help is the initial thing or the first thing you need to do here. Is not the last, as it is mentioned on the slide. So we need to call for help. So this is a recap for what we have been talking about in theory on slides. You can see the summary. And this sketch was taken from the European Resuscitation Council, and you can access that one. And there is an algorithm. I think all of you are aware of this one. Is from UK neonatal resuscitation algorithm. And here there are things you need to focus on. Maintain the temperature through all process. And here you see the golden minute, the 60 seconds. And all time ask, do you need help? Or if you are the one in charge, you can shout for help. Just don't keep quiet. And there is a minute difference on saturation for babies. I think all of you are aware of it. We don't just crave for 100% saturation anytime. For babies who is a minute old, we don't expect 100 saturation. So just keep in track of the minute and the saturation you really need. And when you come to the algorithm, here you see it starts from antenatal counseling. It's not after the birth. You can involve the mother and inform and talk with the mother the status of the baby. And you brief your team who is with you and check your equipment. And after birth, we are talking about the golden minute. You have to do all these things within a minute. Dry the baby after you took to the warm area, radiant warm usually, and assess for the tone, breathing, and heart rate. And if the baby is gasping or not breathing, as we have been talking, you have to open the airway, see the airway, just you can put SPO and correlate with minute the baby is old. And just you can reassess. It is mandatory to reassess the baby. 1 minute is not all. So you'll keep reassessing the baby and you repeat the same thing. And it is on the last resort that you go for chest compression. So we'll see how to do the chest compression in a few minutes. So if the baby continues to be the apneic and the heart rate is less than 60 after you give adequate ventilation and you saw the chest is rising, otherwise there is no need for chest compression. If you couldn't ventilate the baby, there is no meaning for compressing the chest. That's a principle behind chest compression. So lastly, you will debrief about parentheses, as we have been talking about the minute we need to spend on research. With a minute, you can debrief or update the family. And practical and the technique we need to use. And I hope all of you will have algorithm in your hospital or in your institution, but there are basic principles we need to follow. Whatever algorithm you are using, make sure the team members are aware of what you are using. They need to understand in detail of the algorithm you are really using. No need to just use, or there's one thing, during resuscitation is not the time to learn. Actually, it is the time to apply what you know. It's not the time for learning, actually. You can just have your feedback after all. but you need to know what you are going to do as per your algorithm or your institution. And during your resuscitation, just drying and assessing the baby with successful opening of the airway, which matters the most in all cases. And just do not start from intubation. We don't need to go upside down on the algorithm. So just consider displaying the cognitive aid as I've been talking. Just put the algorithm where you are performing your resuscitation. So here is the practical part in neonatal age group. As you see, I think you have discussed this on the previous presentation, likely. I don't know. I'm not sure enough. But anyways, you need to keep here the face in plane with underlying table. So you see these three figures, the one in between, which is neutral. Otherwise, the babies, they are really at risk for minimal manipulation and airway compromisation. So keep the babies neutral because you know all the head of the baby, the occiput is really big. So it will flex the neck and compromise the airway from opening fully. So don't forget to put on flat just table so that you'll get the appropriate position. And we'll see how to use the back valve ventilation technique. I hope you all are aware of the CE grip, and you'll see this one. So here, I think it's really visible, right? So you see the C curve here, and when you include this one, you see for E letter. And when you come to the mask, see how you hold the mask, how you support the mandible, and just chin lifts. And you can use your ring finger and a small finger for just jaw thrusting. And if you're alone, a single person back valve ventilation, you use just dominant hand for back compressing and the other for putting the mask on the mouth and nose. Just for this, as whenever you come across babies, try to put on or apply this technique so that you'll get familiarized yourself with this technique. So when you are with someone, you can use your two hands side by side and apply the same technique. And there is another one. If you are really find it is difficult to open the airway, you can support this way. You see this, the second one on the slide. And when you come to lung inflation and ventilation, just is a term difference. If the baby is not yet ventilated or it is the first time for you to give air, we call it is a lung inflation. And if it is continuing for ventilation, you call it as keeping ventilation. Otherwise, there is no much difference. You keep air, just gas exchange continuing. And when you do this, if the baby is apneic or gasping and not breathing effectively, you use the positive pressure ventilation as soon as possible, as we have been talking within 60 seconds of the birth. And when you give it, just don't rush that much. Use your second, just 2 to 3 seconds. Just give for the air you gave to come back, and so that you'll get adequate time. And ventilation it will continue if the heart rate is not responding, or if it is less than 100 and you aim to keep the heart rate above 100, you will continue ventilation, which is gas exchanging. And you will aim for 30 breaths per minute, and for which inspiration will undertake within a second, within 1 second. Just don't put in a fraction of seconds, give 1 second, so that will expand the lung as much as possible. And you can reduce the inhalation pressure if the chest is moving well, and you can reassess within just every 30 seconds, and you will see the response to your ventilation. And still, there is a place for you to consider the advanced airway manipulation like laryngeal mask or tracheal tube, but make sure your ventilation is really effective, or the chest is moving well. These are just for you to put in big figure, otherwise it's the same we have been discussing. And some of the updates, there is a confusion on suctioning. I think nowadays people are advising don't use suctioning as a routine. You can use if really you think the babies with meconium stain, which is thick, and you think the meconium is blocking the airway, so that you'll relieve from blockage. But still, the efficacy as an intervention is said to be weak. So it's not a routine recommendation to suck babies. As you all see in your practice, you see people run for suctioning, just forgetting about keeping the baby warm and bag masking. So just give attention to the things we can easily perform. And the other is on oxygen usage in neonatal resuscitation. It is said to be using air rather than oxygen is good. If you could have to ventilate the baby well, you can still use air. And so that's it. And the last one is in neonatal resuscitation is the chest compression. As you all know, some of it we have been talking about how you do and when to reassess, and do it when the baby is not responding to your ventilation, even though it is adequate or effective, and the heart rate still remains less than 60 per minute, and you think the ventilation is of good quality, and you can start chest compression right now. And you don't forget to reassess 30 seconds, which is contradicting with the older ones, 2 minutes, like that. So, and when you start chest compression, you can consider increasing your FiO2 to 100%, or you can keep tracking the minute old of your baby and the saturation you expect, really. And here is obvious, you call for help if you are not really ready. And here is the target. You'll aim for ventilating 30 per minute, and you'll give 3 compressions. You all know, I'm sure. And you give 1, 2, 3 breathe, 1, 2, 3 breathe. I wish this had been in face-to-face contact with, so that we'll keep practicing. Anyways, so you'll aim this target when you give ventilation. So you see, chest compression, ensure adequate chest movement. Don't forget this one. Just putting mask and compressing back is not really just ventilation. So make sure you open the airway, the chest is moving, and also raising adequately. And you'll repeat this scenario if the heart rate still remains less than what you are expecting, less than 60. These are all what you have been talking. And when you apply just use synchronous technique. Don't be just incoherent. You need to go with the compression and ventilation 3-to-1 rule. And you can use two-hand technique. You can ask for help if I want to give back, and the other give chest compression and reevaluate every 30 seconds. This is obvious we have been talking about. And the other issue is just you can consider vascular access or drugs if you have access, but still it is not the initial or the priority you need to follow. This is a technique you need to apply when you do chest compression. And here you will see the landmarks. Here, the landmarks are the nipple line, the sternum, and the xiphoid, and you see where you need to put your fingers. Just 1 or 2 finger breaths beneath the nipple line. So you put your fingers there. And if you are alone, you can use your 2 fingers here. And the other hand will help you for stabilizing the head in neutral position. And if there is someone with you, or if you are in a team, you can just use another person to give chest compression with 2-hand technique, encircling the chest. So these are the effective chest compressions, 3-1 roll, and aim for 100 events, which is 90 compression to 30 ventilation, which is like that of adults or big babies. 100, don't aim for 100 compressions, is 90 compression here. So the depth is 1/3 of anterior posterior diameter of the chest, and allow for chest recoil, minimize interruption, avoid hyperventilation, and look for reversible causes as that of another babies. And one thing people forget usually, almost always, is the post-resuscitation care. Once ROSC is achieved, it's not everything's done. We need to keep tracking the glucose level, the temperature of the baby. Here, if the baby is not really in hypoxemic, ischemic encephalopathy state, we don't need to put an hypothermia or therapeutic hypothermia. Still, we can keep the baby in normothermia. So look for your temperature and the oxygenation, ventilation status of the baby, the hemodynamic status of the baby. So don't forget the post-resuscitation care. And when we come to the end, the scenarios, I hope you have been meditating or just thinking about the scenario we have talked on the second slide. So here you can use your easy or simple technique, as we have been saying. Open the airway, give back ventilation. You'll see the babies start to breathe, the heart rate coming up, and you'll be happy. So there is nothing more than this. It will make you happy when the baby is coming to new orbit. Beyond that, the family are waiting for you right there. So just apply the simple techniques. I don't want you to think of intubation the first time. That's why I'm giving great emphasis on the simple thing you can do. And there is a video link. You can use this one. It's the medical aid film. It will go through all the steps and the techniques you need to apply when you do neonatal resuscitation. So you can take this link and see the videos. I think this is okay. So here, I think we need to admit questions or we proceed for the resuscitation beyond neonatal age group. Which one will work? I don't know. Shall I proceed?
Yeah, let's go through all the slides and then we'll take questions at the end.
Yeah, as much as possible. I am just thinking to go through all the slides so that we'll cover as much as possible, because there are some algorithms we need to look at on the pediatric age group. So for this age group, unlike the previous one, there is the ABCDE rule, as you all aware of it. I think you do or you use it in most of your practices as an anesthesia provider or anyone who is dealing with any emergencies. You will use this acronym. So for this pediatric age group, you use the assessment, identification, and intervention technique. So these three terms you don't need to forget as you go through pediatric resuscitation. So the initial thing is you assess the baby who are really seriously ill or injured, and you identify the problem and intervene with the problem. And you repeat the same scenario again. If there is no response, you go through all processes. And you all know this one. A stands for airway. Just open the airway, maintain, and establish it. And when it comes to breathing, you'll see for the rate, the work of breathing. You can estimate the tidal volume or the adequacy of chest rise, or you can just see the expansion of the chest. And even you can see for the color of the extremities or the center for cyanosis. And if you are really in high advanced setup and you can see for capnograph, or you can look for ultrasound. Yes, you can see that. And C stands for circulation. You see for the extremities, whether they are cold or warm. You see for capillary refill and the pulse rate with the volume status and the blood pressure. And so here you can also include the urine output if you can really assess it. And so that's it. And if you found a cardiac echo, you can apply and use it if there is really a skill for using. And D, as you all know, it stands for disability. Here you'll assess the neurological status, the response of the baby or the child, and the pupillary size, it is reactivity, and the glucose level of the baby, the dextrose. Here, don't forget to check for it. And the other one is E. Don't forget to expose the baby and look for any other findings. So you don't forget or you don't miss any finding, which is really significant or putting the baby at risk for arrest. And when we talk about resuscitation in pediatric age group, there are two things. The first thing is basic life support, and the other is really advanced life support. The first thing we need to look is basic life support. As you see from the term, you apply it when you don't have the advanced one. So give attention to the quality of chest compression you are giving, and if available, use the automated external defibrillator. So these things are the mandatory or risky terms you need to use. High quality CPR and AED machine with you. So this high quality CPR, it works for both pulse or pediatric advanced life support and basic life support. So you don't drop it in the basic life support and go to pediatric advanced life support. So you go with it. So you have to practice it very well and know how to do. And when you come to pediatric age group, there is infant age group, yes, except the leaving the neonatal group as a different one. And those beyond 1 to 8 years, there are some differences depending on use of 2 hands or 1 hand. And the other is the site you check for pulses, and the other is the depth of compression. So when you see the site you check for the pulse, it's usually here in the upper elbow, just between the shoulder and elbow, just distal to the arm. So you check for pulse there for infant age group. And the depth is around 4 centimeters in this age group. And if they are beyond 1, you use 5 centimeters. And the other is use of 1 hand technique and 2 hand. Usually you use a 2 hand technique in age group beyond 1 year. So still you can use the 1 hand in age group less than 1 year. So when we talk about basic life support, it's better to have a resuscitation team, and having it alone is not adequate. You need to have a clear communication among yourself with the team leader and the team members of the resuscitation team. So these are the role and responsibilities of team leader and the team member. So the team leader here need to be calm. I need to know what the team members are doing, and he has to organize the group and monitor the performance. And above all, he has to be able to perform all the skills so that he will give feedback and correct the team member in performing good quality CPR. So the team members, they need to understand their role, be willing and able and skilled to perform their role. Otherwise, I say sometimes it is better to give the role given to you if you think you are not adequate enough, you don't think you perform it well, just tell, be loud enough, and give someone who can do that, so that you will not compromise the quality of the CPR. So the team members still should understand the pulse or the basic life support sequence and committed to the team's success. So this is the term we call closed loop communication. As you see, the team leader gives clear assignment to the team member. Here, the team member respond verbally with voice and eye contact here. We don't need to just look down and communicate, just face to the team leader, communicate with eye contact. And the team leader listen for confirmation. And lastly, the team member reports when the task is complete and reports the result. So this is a closed loop communication. So give attention to this one. Sometimes, unless someone remind you, will forget what you are doing or what you need to do. So these are the algorithm for pediatric age group basic life support. I'm not sure. Can you all see the algorithm? Is it visible?
Yes.
So it's okay. So here, the first thing you need to make sure is the baby responding to the environment or any stimulation? And do you have any emergency team or resuscitation team around you? And make sure the baby is not responding and there is no breathing or no pulse. So chest compression here. So there's a high quality CPR, as we have been talking. If you are going to apply CPR, these are the principles you need to follow. And if you are alone, the first thing you need to do is just start chest compression as you shout for help. And the chest compression you do is just, it's a 30 compression to ventilation, unlike the neonatal age group. If you are alone, If you are with someone, we'll see the next slide. You will apply the 15-2 rule. So these are the high quality CPR principles. You aim to 100 to 120 compressions, and don't make it 100. The old version algorithm says it is 100 per minute. Now it is updated to 100 to 120 compression per minute. And the depths, you need to follow one third of the anterior posterior chest diameter. And don't forget to allow for recoil, minimizing interruption at any cost, less than 10 seconds, whatever you are doing during compression. And do not overventilate. This what usually happens because people are in a panic state and we don't remember what we are doing some of the time. So do not overventilate. Keep the time and go with real or appropriate ventilation. And here, if you are AED, you can consider for the rhythm. And if it is really shockable, you can shock. If it is not, you continue the CPR still until you finish the time for resuscitation. So here, this basic one, it will end here. If you have a team for advanced, you continue the advanced life support. So here is the algorithm for a single risk care, basic life support. As we have been talking, you can go through all these slides and the algorithm. You can check for the responsiveness of the child after you make sure the environment is really safe for you to do the resuscitation. And you can shout for nearby help and activate the emergency as we have been talking about it. And just look for the breathing and the pulse rate. And you check it and you continue the risk of breathing and check for pulse every 2 minutes, unlike the neonate, which is 30 seconds. So if there's no pulse, start CPR. You are seeing the algorithm here. If it is less than 60, you will continue it and do the high quality CPR. And here there is two terms. If you witness the sudden collapse, you start CPR or you activate the emergency response. And if you are not really sure which one you need to do first, it will usually make confusion. I need you to be clear with these terms. So the first thing, if you really witness it, you activate the emergency team. If you are not really sure, you start the CPR, do the first cycle, and go for looking for help. The other is the one we have been talking. So the next one is when you are with someone. The difference here, you have extra hand so that you can send someone to call for help and come with EED. Otherwise, the others go with the same principle. And when you come to the advanced life support, this one needs systematic approach. As we have been talking about the ABCD, I don't want to go back and through all this. Here, this one is the algorithm from the American Heart Association. So here it is, as the name indicates, is the advanced one. And you start from CPR. I'm sure you understand how to apply the bag mask ventilation and give oxygen. Still, don't forget, just don't rely only on compression. You need to ventilate with high quality. And here, if you have it, attach the monitor and defibrillator just from the very beginning. If you don't have, you can look for it or send someone with you or call for help and come with EED. And see for the rhythm, so that we are going to apply shock for those who are shockable, and you continue CPR if it's not really shockable rhythm, the asystole and pulseless electrical activity one. And when you apply shock, you use different joules. You can see the side one, the energy you use 2 on the first shock, and go for 4 joule per kg on the second, and the subsequent it should be greater than 4. Usually we use 6 joule per kg and 8. So the rule is 2, 4, 6, 8. So you can apply this one when you perform your defibrillation. So after the first shock, you see for the rhythm again and check whether there is any response after 2 minutes usually. And if there is no any, you continue the CPR. Don't forget to resume CPR within short period of time. As we have been talking, here you can see the high quality CPR still and minimize interruption between test compression. And for those shockable rhythms, you continue CPR and at the same time, look for IV access or intraosseous and see for the rhythm. After the second one, you can consider inotropes, epinephrine. And the other side, you can see the non-shockable one. There is no for shock. Still, you consider epinephrine after the first CPR. So this is the difference here. So you repeat this cycle until you think the time for resuscitation is really enough, usually 20 minutes to 30 minutes. So don't forget at the same time to look for reversible causes. You all aware of it. The 4H or 5H and 40s, you can use this one to really easily remember. So you apply this one for the advanced life support in pediatrics age group. So these are the resuscitation tools in pediatric advanced life support. Unlike the basic life support one, you need to have back mask ventilation, endotracheal tube, the basic airway adjuncts, and the AED, and any material for accessing the intravenous or intraosseous one. And the other is pharmacological tools, because here there is a place for using amiodarone or any other one, other medications. So if possible, try to have them with yourself. And after you do the first or the initial assessment, you need to go for the secondary diagnosis, or you'll give focus on sorting out the possible causes, and so that you'll act accordingly. And when you do this secondary, these are the things you need to go through. The signs, symptoms you see, and the past medical history, allergies, and the medications the baby was taking, any other. You'll go through all these things. And as we are talking about basic, advanced life support, I think this mandatory to now just hint about the normal heart anatomy and the physiology, because we are dealing with the rhythm abnormality, especially on ECG. So it's good to know what it means and what is the normal value for each parameter. So you can have a look at it later when you go back to your practice. So these are the normal values and the intervals and the waves you will look for when you try to identify any abnormality on ECG. And the other issue is the ability to differentiate between a baby in respiratory distress and respiratory failure, so that will act early to prevent the child not to go to respiratory failure while they are in respiratory distress. So these are some of the signs and symptoms you need to know to identify or to differentiate between respiratory distress and respiratory failure. So I don't need to just call every word in the on the slide, so you can see for it. And with respect to the anatomy, you can see which abnormality you expect or you think this the baby is having. Just depending on the upper airway anatomy, you can classify as upper, lower, and lung tissue abnormalities. And still there is a possibility of CNS issues which will affect the respiratory effort in case of overdose or head trauma. So don't forget to look for the secondary diagnosis and abnormalities. And these are depending on the symptoms, jaundice, rider, grunting, and signs, wheezing, and crackles. And so that will be aware of the potential abnormalities in the lab. And the other issues about the shock and their types, at least we need to have the highlights or the basic differences between different types of shock, like hypovolemic, distributive, which we call septic and sepsis and anaphylactic. So the cardiogenic, obstructive. If you know this, you know you will be able to act accordingly depending on the abnormality you found. And depending on the rhythm or the rate, the baby might be in the bradycardic. So here bradycardia has its own different categories. I don't want still to go for each definitions and explanation. There is a first degree. Before that, there is sinus bradycardia, which we will find the P wave for each QRS, but still bradycardic, less than normal for each heart rate. And there is first degree AV block, type 1, second degree, type 2, and the third one. So you can look for it, go back to the ECG, normal ECG, and compare with it, and you can see the abnormalities you really find on bradycardia. And if they are really symptomatic, being bradycardia, you have to go through the ABCD principle, and accordingly you will take the measures you need to take. And here, the medications we use, if the CPR we are applying is not effective to bring up the heart rate, you will use epinephrine and atropine. These are the dosage you need to use. And consider for more advanced management principles like transthoracic or transvenous pacing. You can use these ones if you are in developed countries or well set up setup. So this is an algorithm. Is the same to what you have been talking. You can look through it. There is no point to repeat it at all. It's talking about what you will just see if the baby is really symptomatic, being bradycardic. You will see the baby is hypotensive and there is alteration mentation. So those are things mentioned on this one. Otherwise, regarding the dosage, like that is all the same. We don't need to repeat. And the other common abnormality is the tachycardia. Here, when we talk about tachycardia, we need to think of the normal value for age in pediatrics age group, so that will define as really tachycardic. Here, the assessment also works for, which works for bradycardia, comes here also. So we need to go all through the principles the ABCD rule. Don't forget that. And have the ECG, if possible, the 12 ECG one, so that you'll able to identify the abnormalities in detail. And here there is a classification on tachycardia classification. You can classify as wide and narrow depending on your QRS. Still, that's why I'm raising the issue of knowing some basic on ECG. So depending on the value of QRS, you will classify as wide and narrow. If it is greater than 0.09, you say it is wide. If it is less than, you'll call it as narrow QRS complex. So here there are divisions or classifications for each, whether it is narrow or wide. So if it is really wide, make sure you have the hemodynamic status of the child is stable, and you have cardioverter or defibrillator with you, so that will show if the medication or the medical treatment is really not effective. And if it is narrow, it is usually we call the supraventricular tachycardia. So this is a name given to that. And depending on the age, especially if they are infants, we call it is tachycardia. It's just greater than 120 in child age group. Beyond 1 year, you'll have it is less than greater than 180 per minute. So depending on this value, you will say the baby is tachycardic, and classify depending on your QRS picture as wide and narrow. I don't want to go to the detail because here you see the supraventricular, even it has its own classification, and the ventricular tachycardia even has its own classification as monomorphic and polymorphic. You can go in detail with that. But the basic one is that you can really identify the baby is having tachycardia and which type is it, and the management you are using. So give attention to the algorithm at any cost and go through the principles of management. And here you can see the medical managements or the conservative managements like vagal maneuver and giving medications like adenosine. And if it's not responding, going for synchronized cardioversion and like that. And last but not least, as usual, don't forget to remember about the post-cardiac arrest. So this is what I have for today. These are the references. And thank you. Any questions? You are welcome. Thank you for your attention. Or I think I took a lot of time, long time.
Thank you
Sorry
so
for
much, Dr. Fayisa. That was a great talk. I just wanted to say, people often come to lectures about PALS or neonatal resuscitation and want to focus on the algorithms or CPR, and they underestimate how hard the assessment is to see if you need the resuscitation. And so Dr. Fayisa did a great job talking about the assessment before, and how to assess these children to see if you actually need to start resuscitation. It's really important and can be very hard in the moment. So don't forget that. We are out of time, but we'll stick around for a few minutes if anybody has any questions.